Hello, my name is Tarek Malas, and today I'm going to be discussing the mitral and tricuspid valves. Starting by the mitral anatomy, the mitral annulus is made up of a fibrous ovoid ring that contracts during systole and reduces the mitral valve area by completely closing the leaflets. Now, at the posterior leaflet insertion, the mitral annulus is thinner than other parts of the annulus, making it more vulnerable to dilatation and resulting in adequate leaflet closure. That means that dilatation occurs really in the posterior leaflet portion, not the anterior, which is more fibrous. The anterior leaflet is located at the posterior part of the aortic valve, and it corresponds to 1/3 of the annular ring and 2/3 of the valvular orifice approximately, and is larger and thicker compared to the posterior. The posterior leaflet comprises the other 2/3. As you can see the anterior and posterior leaflets with anatomy of A1, A2, A3, P1, P2, P3 in the surgeon's view. Some critical structures, we have the circumflex artery, which is located in this portion, the coronary sinus as well, and the aortic valve, which is quite close to the anterior leaflet in this diagram. Now, there are 3 layers in the leaflet of the mitral valve: the fibrosa, which is rigid and superficial with thick collagen fibers; the atrial side, which is thinner and towards the atrial surface with elastic fibers; and the spongiosa, which is the layer consisting in particular of glycosaminoglycans and proteoglycans. Now, the chordae and tendonae, there are multiple chordae. Insertion is generally into the ventricle, the anterior leaflet, posterior leaflet, and the commissurals. The primary or marginal chordae are generally thinner and attached to the leaflets at the free edge, preventing leaflet edge to prolapse. The secondary or intermediary chordae are thicker and more extensible and are attached to the ventricular aspect of the leaflets. Quickly going into tricuspid anatomy, the tricuspid valve has an area of approximately 4 to 6 centimeters squared. It's nearly vertical and approximately 45 degrees to the sagittal plane. The anterosuperior leaflet is the largest cusp of the 3 and is located between the conus arteriosus and the atrioventricular orifice. The posterior is the next largest and is named for its posterior position and connected to the posterior aspect of the RV. And the third, which is the smallest, it's the septal leaflet attached to the right and left fibrous trigones and the atrial and ventricular septa. Because of these fibrous attachments, it is relatively immobile. Therefore, most of the tricuspid annular descent takes place along the margins of the anterior and posterior cusps. There's a lot of variability with the pap muscles. They can range from 2 to 9, but usually 2 or 3 papillary muscles can be seen. The anterior, which is the most prominent, and the posterior, which is often bifid or trifid. As you can see, this is the anatomy of the tricuspid valve. We have critical structures here. First of all, in the triangle of Koch, which has boundaries of the AV node, the coronary sinus, and the tendon of the Darrow, just above the fossa ovale. Quickly, I'm going to go through a case presentation of a 38-year-old female who has chronic fatigue and shortness of breath with paroxysmal atrial fibrillation. She presents with vitals of 110 beats per minute, 20 rests per minute, and a blood pressure of 100/60. Physical exam reveals a 216 early descent diastolic decrescendo murmur at the cardiac apex with a prominent opening snap. As you can see here in this video, this is mitral stenosis. Now, mitral stenosis is defined by valve anatomy, valve hemodynamics, and consequences of valve obstruction on the left atrium and pulmonary circulation. What are some of the echocardiographic parameters of mitral stenosis? It's the mitral valve area, the diastolic pressure half time, and the elevated PASP. Now, the diastolic pressure half time also has an inverse relationship with the mitral valve area. In this patient, let's assume a normal EF, MR3 plus, MS4 plus, and a pressure half time of 170 milliseconds. So what are the stages of MS? As you can see, we go through stages A, B, C, D, where A and B are really at risk and progressive mitral stenosis, and then C and D are symptomatic or asymptomatic severe MS. And as you can see, the mitral valve area of like 1.5 centimeters and a diastolic pressure half time of 150 milliseconds. Now, mean pressure gradient across the valve is highly dependent on transvalvular flow rate, the diastolic filling period, and heart rate. So there are some limitations to that. In addition, the mitral pressure half time also has limitations and is dependent upon LV and LA compliance as well as stenosis severity. Now looking at the medical therapy for mitral stenosis, patients with rheumatic MS with AF and prior embolic events are at high risk of developing arterial embolization when an atrial fibrillation or an LA thrombosis is present. Now, non-vitamin K oral anticoagulation has not been well studied in patients with rheumatic MS. Finally, patients with rheumatic MS are prone to developing atrial arrhythmias, specifically AF. Given these clinical pearls, we look at the recommendations here. A class 1 recommendation is for patients with rheumatic MS, AF, a prior embolic event, or LA thrombus, anticoagulation with the VKA is indicated. Now, when we look at the 2A indications, in patients with rheumatic MS and AF with a rapid ventricular response, heart rate control may be beneficial, and in patients with rheumatic MS and normal sinus rhythm with symptomatic resting or exertional sinus tachycardia, heart rate control can be beneficial to manage symptoms. Now, this is an important score that you should know for the Royal College. It's called the Wilkins scores. It's used to describe a mitral valve and to identify whether it's a candidate for a balloon valvuloplasty or surgery. It consists of 4 categories: leaflet mobility, valve thickening, calcification, and subvalvular thickening, each with a different classification, and this provides a Wilkins score. A score of 8 or less predicts a more favorable procedural short, intermediate, and long-term outcome, including survival. Other important predictors of procedural success and long-term outcome include commercial calcification or fusion, pre-procedural mitral regurgitation greater than 2+, post-procedure mitral regurgitation greater than 3, age, prior surgical chemistry, NYHA functional class, and higher post-procedure pulmonary artery pressure. Now, in this patient, we assume a score of 10. So, clearly this is less favorable when we were talking about calcification. The larger the number, the less favorable the mitral valve is. Now, here are the intervention guidelines for patients with mitral stenosis. Looking at first grade 1 classifications, in symptomatic patients with severe rheumatic MS and favorable valve morphology with less than moderate 2+ MR and in the absence of thrombus, PMBC is recommended. It can be performed at a comprehensive valve center. Similarly, in severely symptomatic patients with severe MS who are not candidates, have failed a previous PMBC, or require other cardiac surgery procedures, or do not have access to PMBC, we will look at the second outcome, which is mitral valve surgery as an alternative, and this is indicated as a class 1 indication. Now, there's a poor long-term survival rate in patients who have pulmonary hypertension, and elevated pulmonary arterial resistance before intervention is associated with RV dysfunction and tricuspid regurgitation after the procedure. So taking a look at the 2A indications, in asymptomatic patients with severe rheumatic MS and unfavorable valve morphology with less than 2+ MR in the absence of LA thrombus who have elevated pulmonary arterial systolic pressure greater than 50, PMBC is actually reasonable if it can be performed, of course, at a comprehensive valve center. Finally, we look at the 2B indications. Now we're talking about asymptomatic patients with severe MS and favorable valve morphology. In the absence of LA thrombus who have new onset of AF, PMBC may be considered if it can be performed. Now, if we look at asymptomatic patients, in symptomatic patients with rheumatic MS, and if there is evidence of hemodynamically significant rheumatic MS on the basis of a PAWP of greater than 25 or mean mitral valve greater than 15 during exercise, PMBC may be considered. And finally, in severely symptomatic patients with severe MS who have suboptimal valve anatomy and those who are at too much of a high risk of surgery, PMBC may be considered, meaning, say, the Wilkins score is extremely high, but they are not candidates for surgery. This may be a bailout strategy as PMBC, and that's a class 2B indication. Now, this is all part of the 2020 AHA valve guidelines, and you can see these tree charts, which are important to look at and understand the pathology. Now, in patients in whom there is discrepancy between the clinical symptoms and the resting hemodynamics, exercise testing with measurement of the mean transmitral gradient or the direct pulmonary artery wedge, or both, can be useful. Now, patients who increase their gradients to more than 50 millimeters of mercury with exercise have been shown to improve significantly after PMBC. In addition to those with suboptimal valve anatomy, patients with moderate or severe TR may actually have a better outcome with surgical correction because you can address the tricuspid valve at the same time. Let's take a quick look at another case presentation. This is a 60-year-old male who presents with acute shortness of breath to the ER. This is a chest x-ray which shows pulmonary edema and signs of acute heart failure. Patients with the clinical examination classically reveals a volume-loaded thrusting apex beat and a pansystolic murmur that is heard on precordial auscultation. This is a patient with acutely decompensated congestive heart failure and intubated on pressors and inotropes. As you can see, the echo here demonstrates severe mitral regurgitation. Now, patients with either acute or with patients with chronic mitral regurgitation in the initial stages of the disease compensate with more complete left ventricular emptying, resulting in a supraphysiological ejection fraction. In order to maintain a sufficient forward cardiac output, this compensatory mechanism is met with an increased diastolic volume. Over time, this increases the compliance of the walls of the left atrium and ventricle as response to this volume overload. And this is seen in chronic MR, but not in acute MR when patients present with more critical symptomatology. Now, in general, what are the echocardiographic parameters for mitral regurgitation? Let's say in this patient we have vena contracta of 0.8 centimeters, an EOA of 0.5, regurgitation fraction of 70%, regurgitant volume of 100 mils, and a central jet MR of 50%. Echo further reveals an EF of 55%. The RV has severe dysfunction. It's a filial P2 with a ruptured chordae. So what are his options? Right away we can see with the STS, this is quite a high-risk mortality operation, and there's multiple options, but each case has different options and should be looked at more accurately. In this case, most likely it will be a mitral valve repair or replacement. Now, let's take a look at chronic primary MR. In chronic primary MR, there are the staging from A to B, C, and D. Again, A, B are at risk or progressive, and then C and D are considered asymptomatic severe or symptomatic severe. Parameters, as I've shown previously, are the vena contracta, 0.7, regurgitant volume of less than 60, a regurgitant fraction of more than 50, ERO of less than 0.4 with an angiographic grade generally 1 to 2 in progressive. But as we reach the symptomatic or asymptomatic severe, the inflection, these are the same inflection numbers, and these are numbers that you should memorize for your Royal College exam. Our patient landed in symptomatic severe MR. I know this is chronic, but I was just trying to prove a point just to take a look at these parameters. It's also important to know the Carpentier's classification of mitral regurgitation. Type 1, which is normal leaflet motion, which generally has mitral regurgitation due to either annular dilatation and leaflet perforation. In this scenario, the regurgitation jet is directed centrally. Type 2, which is excessive leaflet motion, such as prolapse. It could result from papillary muscle rupture, chordal rupture, redundant chordae, and this generally produces an eccentric jet directed away from the involved leaflet. And finally, type 3, which is restricted leaflet motion. 3A is leaflet motion restricted in both systole and diastole as seen in rheumatic heart disease, and the jet may be centrally or eccentrically directed. Or 3B, which is limited leaflet motion restricted in diastole, which involves papillary muscle dysfunction, left ventricular dilatation. Again, the jet may be complex, may be central or eccentrically directed. So, in an acute MR, does an IABP help? Yes, the intra-aortic balloon, by inflating during diastole, displaces blood volume from the thoracic aorta. In systole, it effectively reduces afterload for myocardial ejection and improves forward flow from the left ventricle. The net effect is a decreased systolic aortic pressure and increased diastolic pressure. Now, patients do require urgent corrective surgery or mitral valve replacement, which remains a major challenge. The 30-day post-op mortality in this setting may reach 20 to 40%, irrespective of the method of treatment. Now, let's take a look at surgical indications. As we've discussed, parameters of the severity of MR include the following parameters. So, let's start with the class 1 indication. The onset of symptoms that results from severe MR worsens prognosis even when the LV function appears to be normal, and the negative prognosis extends even to mild symptoms. So really, the onset of symptoms is an indication for prompt valve surgery. The goal of therapy here is to correct the MR before the onset of LV dysfunction and its subsequent adverse effects on patient outcomes. So really, the onset of symptoms, LV dysfunction, or pulmonary hypertension worsens the prognosis for MR. So looking at class 1, this makes sense. Symptomatic patients, who have a mitral valve intervention that's recommended irrespective of LV systolic function. Now in those with who are asymptomatic with severe primary MR, and we do have LV systolic dysfunction, which is considered a stage C2, mitral valve surgery is recommended. And finally, in patients with severe primary MR for whom surgery is indicated, mitral valve repair is recommended in preference to mitral valve replacement when the anatomic cause of MR is degenerative, if a successful and durable repair is possible. Finally, looking at 2A, in asymptomatic patients with severe primary MR and normal LV systolic function, mitral valve repair is reasonable when you know that there is a likelihood of a successful and durable repair when the residual MR is greater than 95% with an expected mortality rate of less than 1%, of course when it's performed at a primary or comprehensive valve center. Again, 2A, in severely symptomatic patients with primary severe MR and high or prohibitive surgical risk, transcatheter edge-to-edge repair is reasonable if mitral valve anatomy is favorable for the repair procedure and patient life expectancy is at least 1 year. And this is new in the guidelines for given the multiple trials that have shown the efficacy of the MITRACLIP. Looking at 2B, in patients who are not symptomatic, who have severe primary MR and normal LV systolic function, but who have a progressive increase in LV size or a decrease in EF on 3 or more serial imaging studies, then we can consider mitral valve surgery. Furthermore, number 7, in symptomatic patients with severe primary MR attributable to rheumatic valve disease, mitral valve repair may be considered at a CVC by an experienced team. Rheumatic valve disease is much harder to repair, but in certain centers it may show some efficacy, although limited compared to an myxomatous disease. Last but not least, class 3, which is harm. In patients with severe primary MR when leaflet pathology is really limited to 1/2 of the posterior leaflet, mitral valve replacement should really not be performed unless mitral valve repair has been first attempted. Going on to another case presentation, this is a 55-year-old male with chronic systolic heart failure, numerous admissions for overt heart failure during the past 5 years, EF of 30%, severe functional MR on echo. Quickly going through, These are the cardiovascular findings. On echo, the LV is mildly dilated and the ejection fraction is moderately reduced. The right ventricle is grossly normal in size and EF is grossly normal. And we can see the remainder here. The mitral valve is grossly normal. There's moderate to severe functional MR, and there is mild tricuspid regurgitation. As you can see here, there is significant tenting. We can see that the anterior leaflet and the posterior leaflet are actually restricted. You can see from the plane of the mitral annulus. We can see apical tenting. Leaflet coaptation is displaced. As you can see, the primary MR is more related due to the mitral valve inherently, versus secondary MR, which is more a ventricular disease, which involves the mitral valve and is a more complex entity in these cases. So as we said, primary MR, abnormalities of leaflets or subvalvular apparatus, and secondary due to LA or LV geometric changes with a functionally normal mitral valve. Parameters of severity, as we have discussed, include the following. So what are the stages of secondary MR? We're going to take a look at that again. A and B are at risk and progressive. C and D are severe, being asymptomatic or symptomatic. And these are the inflection points. The ERO of 0.4 centimeters square, a regurgitant volume of 60, and a regurgitant fraction more than 50%, as you can see. There are also associated cardiac findings. So what are his options? As you can see, the risk of mortality is around 5%. There's multiple options. Again, each case we have to look at specifically with respect to patient factors. Now, what are some factors associated with the worst outcomes with significant MR? New development of heart failure symptoms, AFib, RV dysfunction, functional etiology, and certain echocardiographic parameters. Now, what about surgical indications? Surgical indications are really 2A and 2B. There is really no proof that surgical correction of chronic secondary MR is effective in prolonging life. Unless in patients with CABG, but these are sub-patient groups and there's a lack of data. Now, a subset of patients with severe MR attributable to AF may also benefit from mitral valve surgery and concomitant atrial maze procedure. So looking at the 2A group, number 1, in patients with chronic severe secondary MR with LV systolic dysfunction who have persistent symptoms despite medical therapy for heart failure, then TEER is reasonable in patients with appropriate anatomy. And this is what we were talking about, the MITRACLIP. And we'll talk about these as well. Number 2A, in patients with severe secondary MR, mitral valve surgery is reasonable when CABG is undertaken for the treatment of myocardial ischemia. Of course, when we're looking at ischemic MR, there is some evidence, so this is a 2A classification. When we look at the 2B, and in patients with chronic severe secondary MR from atrial annular dilatation with preserved LV systolic function, who have severe persistent symptoms despite optimal therapy for associated AF or other comorbidities, we may also consider mitral valve surgery, mostly for persistent symptoms. Now, in patients with chronic severe secondary MR related to LV systolic dysfunction, who have persistent severe symptoms despite optimal medical therapy, mitral valve surgery may also be considered. And finally, in patients with coronary artery disease and chronic severe secondary MR related to LV systolic dysfunction, who are undergoing mitral valve surgery because of severe symptoms that persist despite medical treatment, we recommend chordal sparing mitral valve replacement. May be reasonable to choose over downsized annuloplasty repair, and that comes from certain trials which we will be discussing as well. In this trial, in an RCT of mitral valve repair versus replacement, 250 patients with severe ischemic MR, mortality rates at 2 years was 19% and 23.2% with no significant difference. There was no difference between repair and mitral valve replacement in LV remodeling. The rate of recurrence of moderate or severe MR over 2 years was higher in the repair than in the replacement group, leading to a higher incidence of heart failure and repeat hospitalizations in the repair group. The higher mortality rate at 2 years in both groups emphasizes the poor prognosis of secondary MR and the lack of apparent benefit of mitral repair over replacement in secondary MR versus primary MR highlights that primary and secondary MR are really two very different diseases. Quickly discussing moderate ischemic MR. In this RCT of 300 patients with moderate ischemic MR undergoing CABG, mortality rate at 2 years was similar in both groups. There was a higher rate of moderate or severe residual MR in the CABG alone group, even though LV reverse modeling was similar in both groups. Now, although rates of hospital readmission and overall serious adverse events were similar in the two groups, neurological events and SVTs were more frequent with the combined CABG and mitral valve repair. Therefore, there is only weak evidence to support mitral valve repair for moderate secondary MR at the time of other cardiac surgery. As we discussed previously, this is the compensatory phase. So once we reach the compensatory phase and we start getting into the symptomatology, this is really the optimal time for intervention prior to the progression of mitral valve disease, which will result in ventricular dilatation, which will result in further MR, which is really a chronic cycle, which can be a detriment of the patient. What about the MITRACLIP? Very quickly, this is just factors that determine prohibitive surgical risk among patients with primary MR undergoing MITRACLIP evaluation. Some favorable characteristics for MITRACLIP placement. As you can see, there's some important criteria which you should know for the Royal College examination. And the definitions of what actually they are. This is a coaptation length versus a coaptation depth, a flail gap between the leaflets, and the flail width as well. Now, just to add some complexity, let's assume that the patient has tricuspid insufficiency. Now, approximately 80% of cases of significant TR are secondary in nature and are related to tricuspid annular dilatation and leaflet tethering in the setting of RV remodeling due to pressure and or volume overload. So, what are the stages of TR and what are some important echocardiographic parameters for TR? As you can see, in this patient, let's assume these parameters. This patient falls thus in the stages of TR in symptomatic severe TR. As you can see, central jet of greater than 50%, ERO, vena contracta with regurgitant volume, etc. These are the inflection points for severe versus progressive. And there's an elevated RA with C wave in patients who are severe. CV wave, sorry. So, reoperation for severe isolated TR after left-sided valve surgery is associated with a perioperative mortality rate of 10 to 25%. It's quite high, so that's why this is a class 1 recommendation. In patients with severe TR undergoing left-sided valve surgery, we recommend doing tricuspid valve surgery concomitantly rather than doing it at a future stage. Now, if you look at the 2A recommendations, so we're looking at in patients with progressive TR, not severe, undergoing left-sided valve surgery, it can be beneficial in these two scenarios. If you have a tricuspid annular dilatation of 40, or there are prior signs and symptoms of right-sided heart failure. Now, in patients with signs and symptoms of right-sided heart failure and severe primary TR, isolated tricuspid valve surgery can be beneficial to reduce symptoms and recurrent hospitalizations. Finally, in patients with signs and symptoms of right-sided heart failure and severe isolated secondary TR attributed to annular dilatation, who are poorly responsive to the medical therapy, isolated tricuspid valve surgery can be beneficial to reduce symptoms and recurrent hospitalizations. Now, the optimal timing of tricuspid valve surgery for asymptomatic or minimally asymptomatic patients with severe primary TR has not really been well established. So this is the 2B classification. In asymptomatic patients with severe primary TR and progressive RV dilatation or systolic dysfunction, isolated tricuspid valve surgery may be considered. Furthermore, in patients with signs and symptoms of right-sided heart failure and severe TR who have undergone previous left-sided valve surgery, reoperation with an isolated tricuspid valve surgery may be considered in the absence of severe pulmonary hypertension or severe RV systolic dysfunction. This is what I was referring to earlier with the high mortality rates in general. Now, what's the idea behind this? Left uncorrected at the time of surgery. We discussed about the high mortality rate, but mild, moderate degrees of functional TR may progress over time in approximately 25% of patients, and this results in a long-term functional outcome and survival that is reduced. And these are some important risk factors. Tricuspid annular dilatation is more reliable than regurgitation because it's actually more consistent. TR is not that reliable because it's really dependent on many factors, mainly preload, afterload, and RV function. Dreyfus and colleagues reported more TR and worse NYHA functional classes in patients with unrepaired TV annuli compared with those of diameters 70 or more, measured from the septal anterior to anteroposterior commissure who underwent repair. 70 millimeters corresponds to about 40 millimeters as measured by echo on an apical 4-chain review. Tricuspid stenosis is not a subject that is very common. It's left out of the new guidelines. So it's really a rare entity, and almost all cases result from rheumatic fever or from post-surgical prosthetic rings. Symptoms include a fluttering discomfort in the neck, fatigue, cold skin, etc., etc. And it's the primary visible sign is a giant flickering A wave with a gradual wide descent in the jugular veins, and can present in congestive hepatopathy or cirrhosis. From older guidelines, this is the stages of TS-H3 with a pressure half time of greater than 190. But this is not a topic that is touched heavily on. Class 1, surgery is recommended for patients with severe TS at the time of operation for left-sided valve disease, and it is also recommended for patients with isolated severe symptomatic severe TS. And then 2B, percutaneous balloon tricuspid commissurotomy might be considered in patients with isolated severe TS without accompanying TR. Thank you for listening to this presentation.